Hello and welcome to today's virtual Hinckley Forum. The Hinckley Institute of Politics is a nonpartisan institute at the University of Utah. The Hinckley provides an array of transformative experiences for students through internships, forums, and classes. Hinckley Forums seek to foster public discourse and civil debate on the most current and pressing issues, bringing in local, national, and international thought leaders. We would like to thank our streaming sponsor, AARP Utah, for making our virtual forums this fall possible. And we would also like to thank our media sponsor, KCPW, for recording and rebroadcasting our forums as part of the Hinckley Radio Hour. Today's forum is Healthcare Disparities and is presented in partnership with AARP Utah and the Office of Equity, Diversity, and Inclusion at the University of Utah. We are joined by our panelists, Rebecca Chavez Hauk, former representative at the Utah State Legislature, Dulce A. Diaz, Director of the Utah Department of Health Office and Health Disparities, Dr. Yvette Lopez, Professor of Public Health, Family, and Preventative Medicine at the University of Utah, and Dr. Jose Rodriguez, AVP for Health Equity, Diversity, and Inclusion at the University of Utah, and our moderator, Jesse Mandel, who is a senior health policy analyst with Voices for Utah Children. If you have questions for our panel, please enter them into the YouTube chat, and we will address audience questions once we have completed the moderated panel discussion. And with that, I'll turn the time over to our moderator.
Thank you so much. Thank you all. My name is Jessie. I'm with Voices for Utah Children, and I'm so excited to host today's panel. And first, I just want to thank the Hinckley Institute, AARP, and the Office of Equity, Diversity, and Inclusion for putting together this incredible and very timely important discussion on health disparities in Utah and in the US. As we all know, health is central to our well-being and livelihood as individuals and as a society as a whole. And while there have been so many innovative medical advancements in healthcare therapies in the US, we are hindered by profound inequities in our healthcare system. And as we will discuss today, the affordability, the accessibility, and the quality of care that people receive varies dramatically based on socioeconomic status, race, geography, gender identity, ability, and many other often intersecting identities and backgrounds. And of course, the COVID pandemic, as we all know, has put a spotlight on these disparities. And while it has heightened these disparities, these are by no means new. So today we have an incredible, distinguished panel of experts to delve into these issues. We're going to start with some data and information to ground us, and we're going to talk about the impact and complexities of health disparities, the role of social factors and determinants, and we're also going to get into solutions so that we are not just talking about the COVID crisis, but we can begin to talk about the root causes so that we're affecting lasting change. I'm very excited for this discussion. And let's start with Director Diaz, who's going to share some information about health disparities to really kick off this conversation, really start us off with the data as it relates to COVID and, as we've discussed, the disparities that have been impacting Utah for decades. Director Diaz, it's you.
Thank you, Jessie. Good afternoon, everybody. I'm really happy to be here and to be able to share this information with you. As all of you know, what is happening with COVID is like a magnifying lens of inequities that many of our minority communities have been experienced for decades, if not centuries. So I'm gonna start sharing some data, COVID-related data with you, so you can see the correlation between the disparities that we see in COVID and with other diseases and the social determinants of health. So we are going to be talking in this presentation about COVID and play and how the COVID-19 pandemic has disproportionately affected disparate communities in Utah. So First, let me introduce to you the Utah's Health Improvement Index. So the Utah's Health Improvement Index is a composite measure of social determinants of health by geographic area. It has been developed by the Utah Department of Health, the Office of Health Disparities in collaboration with the Bureau of Health Promotion. So this index includes 9 indicators that describes important aspects of demographics, socioeconomic deprivation, economic inequality, resource availability, and opportunity structure. The Health Improvement Index is based on Utah small areas and the behavioral risk factor surveillance system. So Utah has 99 small areas. These are geographic areas that range in population between 8,000 and 86,000. 63 of the 99 small areas are considered urban areas, and the rest are considered rural or frontier areas. So the different indicators that are part of the Utah Health Improvement Index are the population with less than 8th grade education, population with less than a high school diploma, the median family income, the income disparity, the unemployment rate, the home ownership, the single parent household with children, and the families below the 150% of the poverty level. So the small areas, the 99 small areas are classified in 5 different health improvement index groups: very high, high, average, low, and very low. The higher the index, the more improvement the area needs. So we consider health disparity areas the areas that are located as very high and high health improvement index areas, and no health disparities areas, the areas that are average, low, and very low health improvement index areas. So the health improvement index also identifies small areas with high numbers of racial and ethnic minorities. So as you can see in the slide, the higher the health improvement index, the higher the percentage of racial and ethnic minorities living in those areas. So the health improvement index also correlates with the percentage of racial and ethnic minorities living in the areas. So there is a strong association between different health indicators and the health improvement index areas. Healthcare coverage is one of them. As you can see in the graphic, the very high and high health improvement index areas have a higher rate of uninsurance people living there. Also, the infant mortality rate correlates with the health improvement index areas. The current smoking, binge drinking, diabetes, obesity, recommended physical activity, food insecurity, all of these are indicators for diseases and different social determinants of health that are really correlated with the health improvement index. So what about infectious disease with community spreads, such as COVID? So what is like, does COVID follow the same pattern that, these other indicators? So let's take a look what has been happening in Utah. As probably all of you know by now, COVID was first identified in the Park City area, which is considered a low and very low health improvement index area because most of the people are really, medium to high socioeconomic status in that area. So this is the case rate per 100,000 of COVID at the beginning of the pandemic in Utah. So the case rate was high in the very low and low health improvement index area, the Park City area. And however, it was relatively low in the very high health improvement index areas. But as the pandemic moved on, a month later, we still see that in the very low and low health improvement index area, the COVID is still present, but it takes out of the high and very high health improvement index area. Why? Because there we have a lot of service people, a lot of people working in the restaurants, the hotel, janitors that didn't live in that area, but of course, they got COVID working there. The progression in May, the very low and low areas, COVID is under control. However, it starts increasing really at a very high rate in the high and very high health improvement index area. Same in June, same in July, same in August. So you see that the numbers are increasing and are increasing really at a very high pace in the very high health improvement in this area. So what this is telling us, that of course we can have an infectious disease can affect any type of community, independently of the socioeconomic status, but when an infectious disease as COVID affects and areas with low or very low health improvement in these areas, wealthy areas, the disease disappears almost immediately. But when the disease affects areas with higher poverty rate and lower socioeconomic status, the disease stays there. And that's what we have seen in the COVID example. And still, this is what is happening nowadays. 8 months into the pandemic, and still the COVID prevalence is much higher in the high and very high health improvement areas, the areas where low socioeconomic and racial ethnic minorities live. So the top 10, 12 small areas with the highest case of per 100,000 population, all of them, most of them are very high or high health improvement in this area, and all of them are areas with high percentage of racial ethnic minorities living there. San Juan County with the American Indian population, and then the west part of the city with a high percentage of Hispanic, Latinos, and Pacific Islanders, refugees communities. And this is the same. The infection rate remains the same throughout the course of all these months. And this is something, an analysis that we did, that it reflects how the, the occupation is related with also the high and the very high health improvement in this area. You see that the people living in high and very high improvement in these areas are people that work in the food preparation and serving related, building and grounds cleaning and maintenance, construction and extraction, production, transportation and material. So you see that the percentage are much higher. And in many of these cases, these are considered essential workers. So what happens with housing density? The same. If you see the quantile, the high and very high health improvement in these areas have a higher percentage of people that live in residence with more than one occupant per room. You see the difference between the very low health improvement in these areas, only 1.5% of the people share the room with another people. However, that number almost is 6 times higher in the very high health improvement. So what all this tell us? Of course, when we talk about infectious disease with community spread, such as COVID, could affect any type of community. But always, the disease, it will be more prevalent and more difficult to control in less affluent communities because of the working conditions, the living conditions, and the access to healthcare. So this is just the top of the iceberg. Why these communities have worse working conditions, worse living conditions, and less access to healthcare? Because structural discrimination that is in the system. And that's something that the following panelists will go more into. Thank you very much.
Thank you, Director Diaz, for that presentation. That was, those are grim numbers, but I think we're all aware of those numbers, and I'm excited now to have a discussion with all of you about them so we can talk more about the root causes, so we can really get into why this is happening, because all too often, I think when we talk about health disparities, or even some of the conversations around underlying conditions, we can see some blaming or shaming. And I think that's what we want to be getting away from. These are, as Dulce was saying, these are social factors. These are societal barriers that are making it harder for people to stay healthy and to combat this disease. So Dr. Lopez, I'd like to start with you. Let's look at those three factors that Director Diaz mentioned at the end, and I'm wondering if maybe you can talk a little bit either about access to healthcare or living conditions or working conditions. I know your research focuses a lot on health disparities and what you're seeing in health disparities as it relates to the data that we've seen and disparities overall.
First of all, can you hear me? You can? Okay. Well,
Yeah.
Thank you so much for the invitation. I'm so happy to be here with you and with these fellow warriors in the fight against health inequities. So thank you so much. So yeah, food insecurity, housing insecurity, education insecurity, and employment insecurity. So where do we begin with this? So to me, as a person that looks at the perspective, from the perspective of the community, we have to look at the community, not just to seek what are their problems, but to seek what do you think the solutions are? And often their ideas are the most, the most workable, the most understandable by the populations, and the most well received, and people are willing to participate. If we don't have that trust, if we don't have that buy-in, I mean, who has time to waste, money to waste in resources, etc.? It's better to go through the people that are visible and known, in order for us to then enter with services and solutions, as it were. So one of the solutions that community comes up with too is that we link up with education, with employment. I work with workforce development for the health professions. And so we can tie all that together by involving community health workers in the delivery of education to health professional students, and also to apply to our research, etc. And I'll explain really briefly. Before the pandemic, it's hit and miss, going to community, going to this fair, going to this thing, and call that community experience. You have an internship, okay, that's more of an experience. But what we are talking about is the integration of those voices as the cake is baking, so to speak. As before they graduate and they practice. And the students are really hungry for this information on health inequities. So that, even though it may seem far removed, is part of a big solution to health inequities, because guess what? We cannot send, I mean, I wish we could. And even the numbers of minorities, doctors, minorities, nurses, etc., and do like this with a magic wand. We don't have that, but we can get there little by little. And by the way, the people that are not of color can help and should help by educating themselves better. So all that responds to what I just mentioned before. I don't want to hog the time.
No, that was terrific. I appreciate you talking about some of the solutions, and also in this moment, I think we really have seen not just the disparities heighten, but a lot of the resilience and the opportunities have been strengthened too, like community health workers. We've known for years that they're so powerful and are so important in our healthcare system, and we're finally seeing, or I think we're seeing that even more advanced in this moment. So that's huge. I am wondering if you can talk a little bit more just around the trust piece, though, because I think that is important to highlight. We're going to be talking about the social determinants, but there is a fundamental, there's barriers are just around access to care and trust with provider. And I'm wondering if you can talk a little bit about that from what you've seen and how those affects disparities to care.
The trust? It's essential. I mean, you cannot fake it. You will have to back up and lose even more time if you try to fake these things. So let me give you an example of an intersection of things. Elder minorities. I mean, they are so far shut in their houses right now. that they need someone to come and reach out to them. And I'm sorry, it just really hurts my heart because of the insecurity of COVID, ay Dios, or the insecurity of, our sociopolitical situation where people feel like, they can come and grab them at any time. And so it makes for a really painful living situation for any human being, but for these people that are our neighbors on the west side of the city and the areas that that Dulce outlined for us. And so the trust again begins with that type of education and that type of exposure and knowledge that this will take time for the people that are not of the culture and for the people that are of the culture to bridge. But we use the community health workers for all of these efforts and it works fantastically. So the trust, for example, to get people tested. Remember ago, it was get people tested. That's a big undertaking for people that have no insurance. And I know it doesn't cost to get tested, but the question is, pero what, then what? Then what happens? So that's it. Then they charge me $500 in the emergency room and then they take me away. I don't want to go do that. There's all this stuff that has to be spoken in a way and delivered in a way that it is absorbed easily and absorbed and understood and accepted. So it goes beyond, translating something in so many languages. That's great. It's fine, but it requires people are not coming in just on their own to get treatment until it's too late. So we need to work on that trust aspect in the community involvement.
Yeah, absolutely. Thank you for sharing that. And I think that's a huge piece of this. And there's historical layers upon layers of reasons why people are going to mistrust. And we see we see that playing out right now. And I'm wondering, Dr. Rodriguez, can you talk a little bit about that too, from your research and what you're doing, and also if you had thoughts or responses in seeing Director Diaz's presentations around health disparities too.
Thank you. I have a lot of thoughts, and thank you, Director Diaz and Dr. Lopez, for your comments. I really do think that trust is essential, and in the many hats that I wear, one of them is to be the Associate Vice President for Health Equity, Diversity, and Inclusion, which essentially supervises and operationalizes diversity action plans and anti-racism plans for the entire University of Utah health system. But I also am a family physician, and my practice is located on the west side in the zip code of 84119, which continues to lead the state in COVID infections. One of the things that we did to try and establish trust was we did a big media campaign and told people we weren't going to be checking documentation. We were not going to be sending their information anywhere else, and that they would have to give us permission to share individual stuff that can be tracked directly to them. First thing. The second thing that we did, and this is something that I have to credit our medical director with, long before COVID. In fact, when the political climate changed in 2016, there was real concern that our patients, who are largely from an immigrant background, either from refugee backgrounds or from Latinx backgrounds, would not feel welcome in something that said that was essentially a state organization, because we are the University of Utah. So our medical director, Dr. Julie Day, put a gigantic sign up in our clinic that says, "Everyone is welcome here." And it says it in English and it says it in Spanish. Those two I can read. And then it says it in 5 other languages that I do not recognize the letters, but my patients did. And they came back and told us, you misspelled a word in Farsi over there. And so we were able to fix it. But it was a big deal to say, trust us, we love you. And that's something we need to continue focusing on. Now, when I talk about COVID COVID is clearly just the magnifying lens, like Director Diaz said. It clearly has amplified health disparities. And I've participated in some of the research that Dr. Lopez has done as well. And what we have found is that health disparities as a whole have been studied now in every institution in the United States for at least 2 decades. And we have not moved the needle. And Dr. Lopez has told me 3 decades, at least 3 decades. In the medical world, really the report that came out that got people thinking about it was in 2002, even though we should have been studying it long before then. Bottom line is this. We've talked about fixing people's socioeconomic status, trying to fix it so people have better jobs and blah, blah, blah. But the one thing that we never tackled was the pervasive, systematic, anti-Black racism that exists in our society. It's ingrained. I mean, it's deep. It's in, I almost want to say it's in our DNA. It's so deep. Bottom line is that has made it clear that the one thing that hasn't been studied is probably where the answer is. And so now we have to go back and work on systemic anti-Black racism and become champions of anti-racism to actually help with health disparities. And it goes way beyond just, what a medical doctor or what researchers can do or public health officials or even community health workers can do. We need to start thinking about essential employees, what that designation really means. And we need to think about the interchangeable racism that exists for Black and brown employees, where employers see them as one leaves, another one comes. They're not individuals. And so there's no protection for their jobs. And if there's no protection for your job, you need to be able to work because there's also no protection for your rent. So we need to think about ways where we can protect people's rent, protect people's jobs, so that when they get sick, they have the ability to stay home. And so I'm very, very passionate about this issue, and I feel like this is a larger legislative discussion. But on the small end, where we are, I think the education of the public is paramount. And I think an important message that has to go out is to please come and see us. If you get sick, come and see us, whether it's by video call or whether it's the emergency room or whether it's in person. But come, we can help. We bought time by going through quarantine. Now we can actually save people's lives. So come, don't worry about cost. Cost is something that's concerning for everyone, but cost can be dealt with afterwards.
Thank you. Thanks for that. It makes me think that I wish we had maybe a day for this panel. So there's a lot that we need to get into. And I think you're absolutely right. We need to put a lens of racial equity in fusing everything. And so I want to unpack that more, but I also want to just highlight what you mentioned too around the working conditions. And that's something Director Diaz mentioned as well. I think in this moment, we are finally starting to see that intersection. And how important where people are working and the access to jobs they have is affecting their health. To that end, I also want to go back to the living conditions issue, the places where people are living, and talk about that a little bit more. The neighborhoods where people are living, the air that we breathe, the social determinants, the access to transportation, the ability to go out into green space. These are all huge, huge issues that affect our health outcomes. And I want to actually ask Director Diaz if you could talk a little bit about that, because that's, I think, essentially what the Health Improvement Index is trying to highlight, that intersection. If you could talk a little bit about the social determinants of health from your work.
So yes, the social determinants of health, as probably all of you know, are the conditions in which people live, work, and play. So it really affects your health, where you live, the work that you have, the conditions of your house. If you have lead in your plumbing, if you live close to the refinery, so if you live close to a source of pollutants, the type of food that you can buy in your neighborhood. Maybe you can buy only, you have only a convenience stores that only have fast food and sodas. So the type of transportation that you have, because many of our underserved communities do not have reliable transportation, so they rely in public transportation. And in many of these neighborhoods, we do not have public transportation. In the last few years, here in the Salt Lake area is expanding, but still, we do not have that. So I think that when we are talking about the living conditions, it's something that always, the American society is a very individualistic society. So it's like we always blame individuals for what you don't do this because you don't want to do this. I'm coming from a European background. I'm from Spain. European countries have a more like a societal or systemic, purpose for everything. So I think that it is important that we stop blaming individuals for the diseases that they have, the conditions in which they live, the conditions in which they work, and we need to start thinking about blaming the system. What is in the system that really, doesn't work for these communities? Because then we can start working and changing the policies at the systemic level, and that will make easier for these individuals to change their behaviors. If you eat unhealthy food, maybe it's because first, you don't have the money to buy healthy food. Second, you don't have a place to buy healthy food. And third, maybe you have been raised, eating that type of food, so you really don't know how to distinguish. So don't blame the individual. Let's bring, let's make the changes in the system so we can bring healthy food to these neighborhoods at a really, and make the healthy food affordable. And then we can educate individuals why it is important for them to eat healthy food, but not the other way. I think that it is important. It is time to stop blaming individuals, and it is time to start blaming the system and make the changes in the system that we need to make for those individuals to have healthy behaviors and have a healthy life.
Thank you for that. Representative Chavez, I'm going to ask you a question in just a minute, but I'm wondering, Dr. Rodriguez, if you would just say what you typed in around the chat around the system, because I think that is really important to highlight. We talk a lot about the system being broken, and is it broken, or how would you interpret that?
So I would say that if we're going to talk about the systems in this country, I think they serve only one demographic, and that is the uber wealthy. All the rest of the people are left out of this dream and this project. We really need to think about the results also, because when I talk about anti-racism work, I talk about the fact that we don't judge people, we judge systems. And we have to recognize that these systems were passed down to us from a very racist and sexist time, full of very racist and sexist people. We don't have to feel guilty about that. We just have to look at the results we have and say, oh, the reason we have these results are because of this system, and change the system. And the easiest way to look at that is to look at the difference between the word equity and the word equality. All right? Equality is the same for everybody, but equity is giving people what they need, and those who need more get more, and those who need less get less. And if we talk about individual families don't work on the principle of equality. If I have 4 kids, that means I spend 15 minutes with each one of them if I have an hour a day to spend with them. That's equality. But really what equity is when Valentina has a science project, I do all of my time with her that day. And then when Pablo has appendicitis, I do all of my time with him. Equity is what makes society work, not equality. So we need to kind of discard that and work towards equity for the populations that need the most. And then we'll be able to see differences in the health improvement index, and differences in the health inequities that are, firmly entrenched in our system.
Thank you for that. Representative Chavez Hauk, from a state policymaking perspective, how do you tackle these issues? How do you try and address the social determinants of health and advanced equity?
So I'm glad that Dr. Rodriguez brought up this concept of equality versus equity, because the challenge that many of us have who have tried to bring forward issues of health disparities and help policymakers and others who have power in our state, the ones that are making decisions about where resources go, whether we make a decision to adopt Medicaid expansion, which we fought for 6 years before we got some sort of a revised version of Medicaid expansion, which only just touches at the surface, I think, in some ways. And what did we lose with the momentum we could have gained in those 6 years of having Medicaid expansion for so many of these populations? The community health workers that Senator Escamilla has been asking for years. And I'm so glad that they've been brought forth, and Dulce and she are working to make sure those community health workers are being deployed appropriately during this time of COVID. But we've been asking for community health workers for years. And the challenge is that a lot of people of privilege, people who have a leg up to say, so to speak, in our community and our society, people who are predominantly white male and heterosexual, I mean, they're the people in power. They think that everything is equal, but it is not. People in power and people with privilege experience all of components of our society, whether it's medical care, whether it's the economy and workplace safety, whether it's education, whether it's housing, whether it's having a living wage, differently than those in the margins do. And I'll share an article that was written by a Dr. Shamard Charles in the chat in a second, and it's called The Intergenerational Impact of Racism on Health. And one of the things that he says at the end of his article is that what can we do to make those societal changes that Dr. Rodriguez and Dr. Lopez and Dulce have all brought up, is the 5 recommendations are to learn, understand, and accept America's racist roots. You just got to start there. Understand how racism has shaped the disparities narrative, and everybody that's spoken has talked about what those symptoms look like. So the way I look at it is racism is the disease, and all of these things that we've been talking about, the manifestations that you've seen with COVID, those are symptoms. Everything that you see in terms of the indicators that Dulce has brought forward in her data, those are symptoms. And racism, institutional and systemic racism, is the disease. So we've got to tackle the disease. He says, define and name racism, recognize racism, not just race, adopt anti-racist behavior and advocate for anti-racist policy, which Dr. Rodriguez has so eloquently brought forth. And then lastly, and this is where we have the challenge in policymakers, with policymakers and others who are in power, whether it's a licensure board, whether it's who decides what people are learning at medical institutions, is that you need to center at the margins, using critical self-consciousness to give voice and power to those who are voiceless or disempowered. And the way that our government works is that it thinks that the center is with the people in power. And predominantly, and if you look at who's making decisions in the state of Utah, it's predominantly white male individuals that are cisgendered individuals. And so if we don't start centering with people at the margins, and we're always operating on decisions that are made related to policy, decisions that are made related to appropriations, where cuts are made. This is where I have one of my greatest concerns as we enter the next few months, as we go into continued legislative sessions and where funding and resources go. Whenever you have a downturn in the economy, you have to watch where those cuts hit first. And they're going to start hitting in the margins. They're not going to be centering people in the margins as they have discussions about where funding goes. And we've been talking about, Dr. Rodriguez, I'm so glad you brought up the point about at the clinics, making people feel welcome. And Dr. Lopez talking about decades and years and centuries of mistrust that is grounded in actual exploitation. And then sometimes people have been killed for the sake of science and for improvement because of who they are, what their race is, etc. And so we've got to shift. How do we dismantle those decades and hundreds of years of people being exploited because of who they are, and then say, hey, now you can come and you can trust us to take care of you, when there are still people in power that think that this is an equal playing field, and it's not an equal playing field. The last thing I wanted to bring up is that, Dulce brought up the issue of like access to food, and I often bring up living wage, transportation, air quality, all of those kinds of things. And with racism being the underpinning, the key disease, racism provides it situates individuals in a constant state of stress. And my physician colleagues here on the panel will talk about, if you are constantly being pounded by cortisol every single day of your life, because you're fearful about whether you can put food on the table. You're fearful because if your son goes out and is mistaken for somebody or another, that they may not come back home. That stress impacts all of these health indicators that Dulce brought up. It brings up, higher levels of the high blood pressure, effects on your cardiovascular system, your impacts on your mental health. So when people say, oh, racism, that's this thing over here, it's not that thing over here. Racism affects all of the things that we've talked about. And when you are in constant stress every single day of your life, when your mother is in stress, when you're in utero, and we were going to talk about maternal health, when your mother is under that impact and that stress of that fear all of her life, it impacts what your health is before you're even born. So all of these things, the foundational underpinning is racism, and that is where we have to tackle through this.
Thank you for that. Yeah, thank you for everything you spoke about. And as you mentioned, we had so many questions that we weren't even able to get to. And there's, I'm so glad you all mentioned that there's just decades of research happening that we have to rely, that has happened about these issues. And here we are talking about them, 3 decades later. I'm wondering, Representative Chavez-Haq, before we turn to the audience questions, if I can ask you one more question, which is, as you're involved in some of the policy and decision-making conversations, do you feel like there's a shift? Do you feel like maybe there's a change? Going back to what Director Diaz said about food, do you think maybe people are starting to think, oh, there's an access issue, there's a community design, it's not just a matter of education, it's not just a matter of poor choices. Like, do you feel like that shift is happening, or not quite yet? How do you feel like maybe this moment is potentially helping us to advance equity in new ways, or what's your experience?
I think it's an opening. I'm hoping we have many people have talked about. There's been a lot of research on how major incidents like this can often really change how things are done going forward within society, and I hope that will happen. My concern is the powers that be, the people that are really making decisions behind the curtain, so to speak. My worry is, as after COVID, that the default it's more comfortable to return to the way things were done because it shores up those power bases. So I'm hoping that there will be changes, but we're all going to have to remain vigilant and say we can't go back to the way things were. We have to reimagine what health looks like, and where all of these adjacent sectors scaffold around health, and how they change, and how we can reimagine doing things differently. But those in power have to be willing to give up that power in order to make that happen. They have to realize, and they have to elevate and lift up those people at the margins, and not center themselves in decision making, whether it's in the halls of political power or whether it's in the halls of corporate power. In all of our institutions in the country, that will have to change. I'm hoping it will. I'm gonna have to say I'm a tad bit jaded. I don't know whether that will or not, but we doesn't mean that we can't remain vigilant and continue to press on doing what we do and working the way we work.
Thanks for that. Yeah, and importance of these conversations, and continuing to have these conversations. I'm going to turn now to audience questions, which are being put into the chat. And the first one that I think is important to talk about when we're talking about healthcare is the role of cost. The question specifically is, what can we do about health insurance companies taking advantage of people and overcharging? But I think those are, health insurance companies are by no means the only ones overcharging and taking advantage of people when it comes to cost. So, I think we can be mindful that there's a lot of cost barriers and cost discrepancies within our healthcare and medical systems. So I'm wondering if any of you would like to tackle that question. Dr. Rodriguez, go ahead. Thanks.
So I think when we're talking about health insurance, we're talking about two things, right? Health insurance is between me and my patients, and they pay me and my patients pay the health insurance company. But what comes to me from the health insurance company is different than what gets to the health insurance company. And one of the things that we've noticed, and this is a business thing, and this is toxic to talk about, but I'm still going to say it, and that is administrative cost. Okay, what ends up happening is that most of your insurance premium doesn't go to your care, it goes to pay people in the bureaucracy, and we need to streamline that. We need to look for equity again, and like Director Diaz said, we have to think about the societal good here. Where is the morality of paying CEOs and senior administrative leaders hundreds of thousands of times more money than their lowest paid workers? They don't need the money for sure. It's just immoral, and we have to think about the societal good. And then there's the other thing. Thank goodness that there is insurance, because if you had to pay directly for costs that are incurred in medicine, it would be cost prohibitive for most of us, including those of us who perform these procedures. So really, we have to look for societal good here, look for equity, and really, insurance companies make money because of the people who pay premiums. So it's imperative that employers and employees make the case for reduction through those.
A follow-up question that came through the chat on that, and I think it's important to mention now as we're talking about getting people in to be tested or treated for COVID. You'd mentioned that you're trying to get the word out that cost is something that can be dealt with later, or that we'll find ways to address costs. But how do you convey that to the people in the most affected communities? That was a question that just came up in the chat. And I know that the Office of Health Disparities has done some really fantastic research on just how much the fear of medical debt and how much can drive people's decision making, and how medical debt can destroy people. So how do you overcome that that fear? How do you tackle that when you're trying to get people into care, as you were saying that you've been trying to do in the clinics where you're at?
So that's a very, very complicated question. I think that the message for the pandemic is that during the pandemic, this is a time for kindness. And we have to be kind as institutions, as healthcare providers, and as, even our billing representatives when it comes to patients. And so we need to have reductions in copays or not charge them at all. And we need to make deals with patients that allow them to make small payments. And I'm talking $5 a month, so that they can actually continue to pay while their incomes and their livelihoods are so threatened. I really do feel that one of the things that needs to happen is that private and public healthcare need to be better intertwined. University of Utah is technically public healthcare because we are the University of Utah, and there's something that comes from the state coffers to us. So the idea that the great majority of our uninsured patients are taken care of by community health centers needs to be re-examined. And we need to take on more of that responsibility as a University of Utah. And we need to better support our community health centers so that they can give the services that are needed to our patients. The truth is that most of our healthcare provider companies here, thinking about the University of Utah Health, Intermountain Healthcare, they're not going to be sending people to collections during the pandemic on medical debt. And so that's what I'm saying. Worry about the medical debt later and get care now, because it's better to have debt and be alive than the alternative. But it's a hard sell, because at the end of the day, there is no protection. There's no debt relief in sight. And really, a smart way of doing things like the CARE Act would have had a provision for those people who will not be able to pay for their COVID care, right? The testing is free, but God forbid you get COVID pneumonia. That's not free. And we should make that free as well.
Thanks much. There are so many great questions coming through the chat. I think I'm going to ask Dr. Lopez one question around medical education and what we can do there, and combine it with, there's a question I see about languages, and so what we can do around medical education to better address these issues. And given the time constraints, if you're able to speak at all to foreign language and how that can play a role, and how medical education can address the language disparities that we're seeing too.
Let's see what we can do. Can you hear me?
Yes, thanks.
Okay. So, sometimes people think, well, what can I do? Do I have a role in this? And the thing is that we all have a role in this. Either we are being harmed by racist, systems, or we are being favored by racist systems, etc. And, if it was hard to remove, I would imagine that, I hope and pray that it would have been removed already, but it holds on. It holds on to history and roots. So what you can do is, whenever you see something, you say something, and you call behaviors out in terms of exclusionary practices. I was in Smith's here in Mill Creek, and so I was talking to my daughter, and you need to go back to your country, because you need to speak English. You're here. And it was so startling, because you think, what? But my daughter said, where do you want me to go back to? Florida? And it lightened the mood. And I just, I said, what do you do? Why are you bothering people? Etc. So we were not the ones that he was hoping to get and shame in the store about language. But whenever we see that people are being short service because of their lack of ability to speak, assist if you can, or create the expectation that the assistance should be provided, wherever it is. Why don't you have anyone that speaks Spanish? Don't you, and assist that person, even though you're not of the culture or whatever, or if you are of the culture, then even better. But advocate so that we can make systemic changes. That gets written down somewhere, that gets observed, somebody will complain, follow through with these things, even if you speak English. Do this for our common good. We just need to be kinder to each other in general, and think about the common good. And, so I am always hopeful. I always go back to the students. They give me hope every day, because I think, well, when they come out, they'll have so much more than I had, or so much more than last year's, or, I can't help it. I'm an optimist. Did I speak to everything? I don't know.
That was great. Yeah, I think and ending on an optimistic note is always appreciated in this moment. We're almost at time, so I think we're going to take an audience question that came through. I'm going to kind of combine two for that final question to the panelists, which is, in this moment, what can we be doing to advance health equity? There was a question about what can everyday people do to address health disparities, but I think also what can we be doing to change the system, right? Because we've had a lot of great conversations that we don't want to center this on the individual, right? We want to center this on the systems, and we want to change these systems. And How can we do that together? What's the best way? What's a takeaway that you all might have for as we're moving forward? So Rebecca, Representative Shabasak, I'm going to start with you. How do you think we can be moving forward to advance equity in this moment?
So I think that if you're a person that has any kind of privilege, and most of us do, but if you do, I invite you to move away from a space of scarcity, and look at the assets that we have and help to lift those assets up. And to, question your legislators and others about why are you making cuts to Medicaid clinics, for example, or why are we cutting Medicaid clinics? Just at a time when individuals need these resources, and holding those individuals to account. Learn the history. I'm learning a lot myself. I often feel very cheated presently about stuff I didn't know, that we just don't know about our history. So learn and then just be a student of what our history was that situated us in this place where we have elevated systems because of systemic racism. And I think that even in that learning, that will help you know where you can best advocate, and avoid stigmatizing populations. Understand that the reason that they're at where they're at is because systems have placed them in that position.
Thank you. Thanks for that. And maybe we can include a few, there's been some great links that we'll be hopefully following up with. And in addition, we'll include one around how to contact your legislators, because I think that's very important also to that point. Director Diaz, I want to ask you the same question. What do you think we can be doing to advance equity and to help move things forward?
I think that the two issues that have been brought out by Dr. Lopez and Representative Chavez are really very important. If you see something, say something, speak out, and also contact your legislators is really very important. And I think that think about this issue of discrimination. This is a power imbalance, and this is discriminations maybe based on your national origin, based on your religion, your race, ethnicity, your gender identity, your sexual preference. So there is a power imbalance, among all these groups. So it's like we need to address discrimination as a whole. It is important, again, we need to change the system. It's not going to be easy to change the system, and it cannot be done in a radical form. It's like we have to do it in a way that is going to work for everybody if we want to avoid, like a big catastrophe. So it's like, I think that we need to talk to people, talk to your neighbors, talk to your family, talk to your friends about this, have this conversation. This is an uncomfortable conversation to have. But I think that now, one of the things that COVID is giving us is an excellent opportunity to talk about health equity. Why COVID is happening to certain people. It's like, why do we see the disparities that we see in COVID? So everybody's talking about COVID. So let's use the COVID excuse to talk about health equity. And just be curious, watch documentaries, read articles, read books, and become more familiar with this issue of health equity. And then you realize that advancing health equity is beneficial for everybody, not just for the people that experience. If we really want to have an equal society, we need to be involved. All of us need to be involved one way or the other. So yeah, read about health equity and talk about health equity. And this is and I think that COVID is giving us the perfect excuse to talk about health equity.
Thank you for that. And that also creates healthier societies, that's which we're all concerned about. Thank you so much for that. Dr. Rodriguez, same question to you. What can we be doing in this moment?
We need to vote. That's the first thing. And then we also need to the word that I want to use is to amplify the voices of the marginalized. Think about those people who are suffering the worst from COVID. We need to get their concerns taken care of. That way, all of our concerns get taken care of. And this goes to everything we do. whether we're in leadership at a university, at an institution, whether we're in management, whether we're in employees, there's always going to be someone who has less privilege than I do. And my job is to amplify their voice and make sure it's heard, because that voice is the voice that's going to take us to change.
Thank you for that. Absolutely. Dr. Lopez, any final words from you around this and how we can reframe the power dynamics to see power where it should truly be in this moment?
I want to echo what everyone has said. These panelists have been excellent. I'm so proud to be among them. And also add that often we think that our actions are not important or significant, but pay attention and support people that need to be supported around you. I carry numbers of people like the refugee center because I don't speak every language. When I see people having difficulty, at least I have a number that I can go to. So be concrete. If you work somewhere that you need to have a policy developed as to what to deal with when someone that is undocumented comes in and we don't want to create any track record issues for them, have a policy in place that advocates for the people that are at the margins and that we need so much.
Thank you all so much. This has been a fantastic conversation. I only wish we had more time to keep talking about these issues, but I'm so grateful and honored to have been part of this discussion and have learned from all of you, and look forward to more conversations together. We will be posting information in the chat and sharing this, this discussion. So please share the links, please check out the links and share this webinar after it's over. And with that,
Thank you
all. Thank you, Hinckley Institute, AARP, and Office of Equity, Diversity, and Inclusion for sponsoring us, and look forward to future conversations together. Thanks.